Morning, everybody.
Morning.
Greetings from the land of the bird of paradise. My presentation is on adapting our national strategy to a socially and geographically concentrated epidemic, a case for the country. A quick outline of the presentation, what adaptation really means for our response for PNG, the evolution in understanding of our epidemic and its response, current trends and adaptation, the broad challenges that we face, and some concluding messages. So what does adaptation mean for our HIV response? The first thing is a progressive understanding of our epidemic so far. Secondly, to ask questions against the interventions in light of improved understanding of our epidemic, an ongoing adjustment of intervention activities in light of the new evidence, and lastly, to build capacity of implementers to adapt what they do to the changing epidemic. The epidemic in the early 2000s was seen as sharply increasing with annual HIV diagnoses. There was limited access to testing and treatment services and little information on prevalence in the general population, and particularly for those at highest risk of HIV infection. And it was declared as a generalized epidemic by UNAIDS in 2004. And around that time there was wide speculation of a sub-Saharan African type epidemic with interventions based on the generalized epidemic. And the epidemic currently, there's broad evidence that we have wide access to HIV testing and treatment. There is now good data available on HIV prevalence, particularly in antenatal care, women attending antenatal care through sentinel surveillance, and some information on behavior and prevalence in those at highest risk of infection. The overall burden, we have an estimated prevalence of adults between the ages of 15 to 49 at 0.65%. There is an estimated just over 31,500 people living with the virus, and we have over 3,000 diagnoses of new infections annually. So we now regard ourselves as having a concentrated epidemic amongst key populations. Our prevalence is highest in nine provinces out of the 22, the 7 Highlands provinces, and the capital hub in Port Moresby, and our industrial hub in Lae, which is connected to the 7 Highlands provinces. 90% of all our cases are reported from those 9 provinces. Our key populations: female sex workers, men who have sex with men, and transgender individuals. The data that you see, or the graphs that you see, our sentinel surveillance data, the trend data on your left hand, and the survey data amongst our key affected populations. Women who exchange sex from the Asking Nasabe survey, 19%. Men who exchange sex, 8.8%. Transgenders who exchange sex, 23.7%. And men who have sex with men, 9%. The PNG response from 2001 up to 2010 was guided by, firstly, the medium-term plan and the first national strategic plan. The strategies were based on generalized epidemics. There was a similar suite of interventions for all population groups in all the provinces. Prevention was synonymous with awareness. There was little emphasis on the STI epidemics that we have in our country, which is about 10 times the size of our HIV epidemic. There was no explicit focus on the most at-risk populations. Only 1% of our total national response funding benefited the MARPs. The turning point is with the current NHS. It identified top 10 interventions for resourcing. It gave some attention to the most at-risk population and identified and prioritized high-burden provinces. And in particular, the midterm review of the national HIV strategy in the middle of last year that recommended a rethink on our prevention approach to prioritize our most at-risk populations, recommend different packages for high and low burden provinces, adopt a continuum of prevention, care and treatment model of service delivery, and to recommend a review of the structure. And from our national aid spending assessments 1 and 2, it was highlighted there was limited spending on the most at-risk populations. Our current efforts and adaptations, firstly is to improve our evidence. A synthesis of program data and size estimation of our most at-risk populations is underway. There is preparation for integrated biobehavioral survey for the most at-risk populations and limited coverage of general population in selected high-burden provinces. A reviewing of our reporting templates to include the most at-risk populations' specific indicators, and really to improve our program reporting. Secondly, our programming shifts, rethinking prevention and adopting a continuum of prevention through to treatment and care model to strengthen link between clinical and non-clinical interventions, differentiated responses, different package for different provinces and population subgroups, the mapping of hotspots for the most at-risk populations where most at-risk populations converge, a comprehensive condom programming policy, greater engagement of the MARPs, making them central to the response, enhanced advocacy and rights-based approach. And I might just add here that Papua New Guinea is no different from Mauritius and in particular Jamaica. As a former British colony, we still have the draconian laws that were spoken to by Marcus. Thirdly, resource realignment. There has been an increase in resource allocation for most at-risk population activities from 1% in 2009 to 9% in 2011-2012. There's been an increase in the number of implementing organizations working on MARPS programs. We've certainly had some new partners come in particular from the churches. And there's more funding for activities in the 9 high prevalence provinces. We've also had to review our HIV architecture, and it appears that the National AIDS Council and its Secretariat will be integrating and amalgamating with the National Department of Health, which is underway. There's a greater decentralization of management and coordination functions to our provinces, and getting some capacity development with the aid of donor partners for our implementing partners. Broad challenges for the PNG response. An inadequate evidence remains a concern, and in particular, as I alluded to, legal barriers. Same-sex relationship and sex work in PNG are illegal. The transition from a dual to a single architecture for the HIV response. Funding uncertainty, 76% of the response is external and 2/3 of that comes from DFAT, Australia. Tension between advocating for the rights of MARPs and the widely held view that PNG is a Christian country once again reflects what Marcus was saying. And there's the capacity for evidence-based programming and implementation is also seen as a challenge. Concluding messages. Understanding of PNG epidemic has changed with improvement in evidence. The earlier prediction that it would follow the sub-Saharan African trend was inaccurate. Current evidence points toward a concentration in key populations and in 9 of the country's 22 provinces. The response has evolved with the evolution in understanding of our epidemic. Current efforts are aimed at improving evidence, creating the enabling environment, and realigning resources to ensure more focus on the most at-risk populations. Our greatest challenges lie in achieving legal and institutional reforms, improving implementation capacity and sustainability of responses, particularly in our provinces. Thank you.